So we'll start right away. We've spent a lot of time discussing barriers, facilitators, evidence, no evidence. We want to move into something that's a little bit lighter, but very important and very exciting. I heard a quote recently that someone said that over the next 5 years, the most important person in a care team is probably going to be a mobile app developer. It probably is not that out there, that could be possible. So today's panel here is going to take you a little bit further away into the future. We're going to talk about how mobile health, mobile phones, smartphones, social media, remote monitoring, wearable devices, sensor devices, all of these really cool and exciting technologies are going to make their way into healthcare. How are they important and how should we be prepared for them? So keeping with that, I'm going to quickly introduce our panelists for today. We have David Munz, who's going to talk about patient provision of data, Bonnie Britton, who's going to talk about remote patient monitoring, Dave Clifford from Patients Like Me, who's going to talk about patient support groups and social networking, and then Mohit Kaushal, who's going to talk about the future of wireless health. You have bios of all these speakers, so without further ado, we'll start off with David.
Thank you very much. You'll be able to tell from my accent that I'm not from around here, so I hope that you can do simultaneous translations. Let's go ahead and move to the first one. I appreciate what Dr. Schwam referenced here, and that was The Field of Dreams. I happen to be a movie buff, and it's one of my favorites. And the quote, "If you build it, they will come," certainly very popular, and I really believe the reference there is appropriate, and I wanted to use it earlier this morning, so I appreciate that you're doing that. But the truth is that when you talk about if you build it, they will come, it was talking about the players, not about the people who are going to be there in the audience to see it. And what I would like to spend my time is talking about how we're going to get the audience to come. And right now we have not seen a lot of progress in that area, though we see bright spots. I'll try to quote some of the figures that show the challenges that we have. And what I'd like to do is to get everybody here to feel some personal responsibility for helping bring everybody into the field of dreams. So I think it's pretty obvious that we all have unbounded expectations. The fact is I carry devices on my hip. I expect them to do remarkable things. Everybody does. It affects the way that I used to do work when I was a chief information officer. And in fact, there are different planning horizons than we used to have. We used to have short term, which was whatever you defined, and there was a midterm, and then there was a long term. Well, I think what has happened with the presence of the mobile devices is that we have a new planning horizon, and that's the immediate term. And so the expectations are now that when you see something, it's going to happen a lot more quickly. And when I hear the people talking about the studies, we're going to have to figure out how to do things a lot more rapidly to get the technology into the hands of the people. The other thing that's going to happen is the people are going to have the technology, and we're going to have to figure out how to deploy it more quickly within our own areas. In terms of the roles that we see changing, I think that the question is who is going to be the primary coordinator of care and the secondary. Is it going to be the physician with patient-centered medical homes, or is it going to be the patient or the patient support groups? And I think those conversations are important. Now, I do appreciate and want to say thank you to everybody who mentioned meaningful use today. I won't really dwell too much on that because I appreciate everybody else's. But I'd rather talk about the meaningful conversations that occur as a result of meaningful use. And what we really need to do as we're deploying this technology is get into meaningful conversations where we discuss what the roles will be for the respective parties, because it's not about the technology, as everybody has pointed out. It's all about the people and the processes. In terms of community or affinity groups, there are plenty of them out there, and they are helping each other. But the question is, how do you get them connected? The other thing that's very interesting is this potential change in who's going to be the custodian of data. And I had the privilege of speaking to the American Health Information Management Association. And right now, in most states, and I would say virtually all, the medical records person or the health information management person is considered the custodian of data. So when I went to speak to them, I said, I think we're going to see a significant shift. And I was expecting a pretty negative reaction, especially at a national group where these people are doing the things they do every day. And I said, what I expect to see is a complete shift. And no longer will the health information management people be responsible as custodian of data, but the patient will become the custodian of data. And the truth is that helps solve some significant problems. Privacy, confidentiality, security, access, all those problems go away. Well, that's a wonderful notion if you have an educated populace. The fact is we still have a significant digital divide. So for the people who can take advantage and be custodians of data, we want to promote that. For the people who can't, we're going to have to figure out how to do that. And that's going to mean health information exchanges, and then somebody else will have to be that primary coordinator of care. And when you think about I'm from Texas, where there are 30% under or uninsured patients. And so that digital divide is pretty large. And we do need to figure out at the same time we're taking care of the people who have crossed the divide, how we're going to take care of the people who have not. These are the couple of things I'm not going to dwell on. ONC was started many years ago. And when it did, there were only 28 people. We are now at about 180 people. And strangely enough, being an outsider, I've only been there 7 months, first thing I noticed was that things weren't organized exactly like I would expect. And so I had an opportunity to talk about how we should change the focus a little bit. And though we talked about consumers, we didn't have a place where we could go to represent the consumer. So now, inside the Office of National Coordinator, there is a consumer e-health group that focuses entirely on that. And the work had been going on, it had just been going on in diffuse ways. And so what I'll show is some of the examples of what has already occurred and talk about what some of the things we're going to do are. We do have 3 A's that we talk about. Access, which is pretty straightforward, is that how do you get a patient to the data? Action is how do you get a patient to take action on the data, and then how do you change the attitudes about care? And when we talk about the market for mobile health, and I appreciate your comment, I have a quote here. And by the way, these quotes I have are all within the last week. So it's incredible how relevant all the activities are that we're engaged in. But it says the market for mobile health applications is continuing to grow and is expected to reach $11.8 billion in 2018, according to global data. So pretty remarkable. And what we need to do, we talked a lot today about the providers. We also need to simultaneously be talking about the patient because the role they have is so critical. In terms of what the personal health ecosystem is like, Continua provided this slide. Continua, for those who don't know, is a group of 220 organizations, includes providers, vendors, other interested parties. And when you see this, it's kind of daunting, and the question is, does this really exist? Well, the fact is, it really does exist. Here's some examples of products that are currently available in the market to do such things as chemistry through smart Band-Aids, and then the ability to communicate this. It makes telehealth accessible now. The question is, how do you package it? How do you make sure you get reimbursed for it? How do you make sure that people get trained for it? So we'll talk a little bit about that in a minute. In terms of this is very important. And by the way, the definition of elderly keeps changing. The older I get, the higher it goes. But the fact is my mother is substantially older than I am, so I'll at least say that I do worry about her exercising enough to avoid a fall. And the question is, what's available? Well, this is actually a slide from 2009. So the technology has been around for a while. And the fact is, you can watch what the activities of daily living are inside a household. And the question is, can you afford to do it? What's the reimbursement model that's going to support it? Very interesting possibilities already in existence. And then the smart car. This is probably a little invasive, and I actually got in one of these cars, and when I got in the driver's seat, it said, please, only one driver at a time. So I was a little insulted. But the fact is that even our thank you finally got that. Yeah, good. Even the automobiles are smart. And the fact is my car has more technology than any prior moon landing device, and so it's just remarkable what goes on. The question is, how are we going to use the technology? What are we going to do to gather the information and then be able to take particular actions associated with it? If we look at some of the challenges here, it's, again, how to engage the patient. There are some cultural things that go on. There are some discussions, again, meaningful discussions that have to take place. What do you do to make sure that an adolescent's record, is it always the mom that should do that? The rules in Texas are pretty specific about what a minor is, but if we're trying to deal with sexually transmitted diseases, how are you going to be effective if you don't let the individual who's associated with that tell you what the results are? How are you going to inform people about what needs to be done? It's huge. Literacy. We talked about the digital divide. Well, people don't know how to use computers. If you want to learn something, give a device to a teenager. They're the best training manual you could ever get. And yet, why are they so used to it and the people who've been using it for a long time are not? So it has something to do with that. Well, there's an age thing. And so domestic demographics and domestic politics, which will be affected by that, are going to be impacted by this. Privacy and security and confidentiality, you know, all of us have said this before, but there are things that you will tell your physician that you won't tell another soul in the world, whether it's your priest, your rabbi, imam, best friend, and you've got to figure out how to do this. Well, again, getting the patient involved in this is huge, and then it affects the relationship with the provider. Who hasn't gone into a physician and said, I looked online and here's information, and the question is the physician going to be able to keep up with that? And we saw a slide yesterday that talked about the increasing availability of information. If information is doubling every 2.5 to 4 years in the medical space, how is it that the physicians are going to keep up? And will there be some competition that develops once the patients have access to the same kind of information their providers do? The reliability of information is a huge thing. And people always question whether the reliability of the patient data is good. You know, one of the things that physicians do when they're assessing a patient is understand, is the patient the real source of truth? It's the reason that body language is so important during an interview. Well, the other question is, what about the physician's data? How reliable is it? And some of the patients have discovered that some of the information that goes into their medical record is not accurate, and the question is, how do you deal with those kind of issues? So, again, having everybody look at the data ensures that the value of the data goes up and the integrity of it stays as high as it's possible. Intuitive collection of data. And I think that probably something that's intuitive is required. The fact is, if you have to train on an electronic health record or a personal health record, you're probably not going to use it if you're a consumer. We know already what the situation is with physicians. If you want to train them, you really need to do at-the-elbow training. That comes from years of trying to do classroom training. It's just not effective. So why not give people software that's been designed better? And we did establish a new office within the agency that's called the Chief Medical Officer. And one of the responsibilities that he has is usability. It has huge implications for safety. So if the device is intuitive, easy to use, and is able to ensure that safe measures are put in place, it will deliver a better outcome. And then one of the things that I hear people talk about a lot is the work-life balance. The question is, if we really got it right, shouldn't it be life-work balance? So when you talk about consumers, instead of talking about workflow, I think we probably ought to talk about life flow. And that is, how are you going to incorporate the technology into the lives of the consumers? It's got to be unobtrusive but always available. And if you're going to train chronic conditions, and 78% of all disease is chronic, you're going to have to figure out a way to make this happen. So I hope again that we will be having discussion about the meaningful use of the technology, not meaningful use as defined by the ONC, though I certainly like that definition. And consumers are looking for a trusted source. And, you know, it used to be that I laughed at this, but a report just came out 2 days ago that really is pretty disturbing. The Journal of Pediatrics, have you seen this article? It's remarkable. It says, a new study published in the Journal of Pediatrics examines Google search results for various phrases related to infant sleep safety. And I happen to be a grandfather now, and I can tell you this is a huge issue for my daughter. Frankly, we're through the part we had to worry about, but she was very concerned. The study notes that 28.4% of the online search results provided irrelevant data, which is not really harmful, and 28.1% provided inaccurate data. So if we want people to use data, if we want people to come to the technology, if we want people to be information stewards, we're going to have to figure out a way to improve the integrity of that data. And here's what I think is one of the most remarkable evidences of how important it is to get the patient involved. And AARP did a great study that showed these results. And it is incredible when you have a more interested, engaged patient, what the outcome is for their health. So as we talk about trying to do health reform, you have to have the patient right at the center of the discussions. It's not just enough to put up new payment models. You've got to have a different behavior in the patient. And here's the kind of concern, because there is a gap between reality and potential. And this is pretty remarkable. Only 15% renewed a prescription online. And how many in this audience have ever renewed a prescription online? Okay, this is a much better audience. You're at least twice as good as the general public. So please continue doing that. And here's another thing that, again, I find a little disturbing. And so it's not that it discourages me. It actually encourages me to be more enthusiastic about what we're doing, and I hope you will get that way as well. But data from the third annual EHR online survey conducted for Xerox by Harrison Interactive showed that only 26% of Americans wanted to adopt digital health records. Also found that only 40% of respondents said digital records will boost healthcare delivery, and that's a decrease from last year of 2%. So things aren't going in the right direction. And it's going to take people like you and people like me out there trying to encourage people to do what's right and good for them. It's really difficult to do what's right for somebody else. What we're trying to do, and we've been very successful, and I would encourage everybody in here who is not already a member to join the Pledge program that's put out by our Consumer eHealth Group. We have 350 organizations, represent over 100 million Americans, which is a really nice portion of the populace. Both data holders and non-data holders are encouraged to participate, but you can look up here and see a lot of very large companies are well represented, and I'm glad to see Pepsi is up there, since they're the ones that are helping produce the snacks that I eat, and making this a little more challenging. But the idea is we need to figure out how to put the I in health IT. And these stories that we post out on healthit.gov are actually stories about people who have used health information technology to do real things. And there's nothing more impressive than anecdotal evidence. So here's a cancer survivor who was able to actually dance at his daughter's wedding because of some things that were done and enabled by health information technology. The Million Hearts campaign, I'm sure everybody is familiar with. The idea is get out there, get the individuals committed. I think it's being a remarkable success, but we need to do more. We have actually tried to engage the developers and try to get the real people out there to do testimonies, and this was a prior challenge that we put out where we actually offer money to get people engaged. This was a beat down blood pressure, which I thought was a very clever name. We now have something that you can go out there and do right now, and this actually ends on August 20, and there is money available to you, $7,200 in prizes, and we're certainly not beyond paying people to get engaged, but you can see that it's an opportunity to tell your story about how you use technology. So I would encourage you or any of the friends to get engaged with this. I think you probably know about the Blue Button and how many people have actually already downloaded records. This is available from the VA and the DOD, and we've been in conversations with them, so we're moving some of the activities over to ONC. And what we're trying to do is to figure out how to do it not just in data blobs. Right now, the data that comes down comes in text format. And so what we want to do is take it to the next level, and that is provide data to the patient in discrete format so that you can incorporate this automatically into your personal health record. The other thing that is required by the current deployment is that you have to go out and click on the blue button. What we'd like to do is create a set and forget it kind of environment so that your data gets downloaded to you automatically. And I think that'll be something that you will see us working on within the next year. And so I'm going to end with 3 seconds left. Oh, I'm over by 5 seconds. But I'd like to end by asking you all to connect, communicate, and collaborate. The patients, the consumers deserve everyone's help. And if you really think about the easy way to sum it up is you help an individual, you actually help the population. So I would encourage you all to go out there. We just yesterday released a small cartoon, actually, for the public to help explain to them in ways that may be a little more accessible what an electronic health record can do, and this is the link for that. And I would encourage anybody who has any ideas or thoughts that we don't cover today to go ahead and contact me at the email address that's up on the screen. And I'd like to thank y'all for your attention.
Good morning. How is everyone? Good. My name is Bonnie Britton, and I'm really excited to be here to talk to you about a remote monitoring program that is new and a little bit unique, and some of our outcomes that we've had thus far. Let's see. I work for Vidant Health. It's located in Greenville, North Carolina, or the eastern part of North Carolina. We're the largest healthcare system in North Carolina. We have a little over, right at 1,500 beds. We provide services to patients in 29 counties and cover 1.4 million lives. We're also affiliated with ECU School of Medicine, East Carolina University School of Medicine. Here is a map of eastern North Carolina. We're very rural. In 7 of our counties out of those 29 are the top chronic disease counties in the state of North Carolina. We have a tertiary care center at Vidant Medical Center right there in the center, and then all of the hospitals that you see around. There's 10 hospitals total in our health system, as well as home health, hospice, and we also have Vidant Medical Group, which are primary care providers scattered all across. We have 50 practices right now, and that's being expanded to about 150. I want to talk to you a little bit about some of the successful programs that we've had in eastern North Carolina. Being in a very rural state and in a state in an area where there's a lot of poverty, a lot of illiteracy, and number one in the state and several of those counties for our chronic disease. I worked previously with Roanoke Chowan Community Health Center in Ahoskie, North Carolina, and we implemented in 2006 a patient-provider telehealth model, which really looked at, in a community health center, how primary care providers could identify their patients and then refer them to remote monitoring, where we would monitor the patient's blood pressure, pulse, their weight, their oxygen saturation, as well as their blood sugar levels. And we had so many good impacts with our patients that we were able to expand that program. And at one time, we were doing all the centralized monitoring from one location in rural eastern North Carolina to up to 12 community health centers across the state of North Carolina. Currently, there are 3 community health centers in North Carolina that are monitoring patients, as well as Roanoke Chowan. So that is 4 in total. The average length of stay on telehealth of that program was 6 months. The outcomes that we had, we contracted with Wake Forest University to conduct our outcomes, and we demonstrated statistically significant reductions in bed days, hospitalizations, as well as overall health care expenditures. As a result of those outcomes and the program that was developed, I was recruited to come and work with Vidant Health August of last year. It's almost been a year. And what I was tasked to do was to write a business plan and to implement a remote monitoring program for patients with cardiovascular disease as well as pulmonary disease for all 10 of our hospitals. So what we have done is the hospital itself paid for this program. It's self-funded through the hospital. The reason that they're doing it, obviously we've talked about those things the last 2 days, value-based purchasing, core measures, public reporting of outcomes, and the other area is to decrease the 30-day readmissions. As every hospital knows, the penalties that are coming starting in October for having high numbers of readmissions for heart failures, acute MI, and community-acquired pneumonia are going to be quite significant. And so what Vidant Health wanted to do is to try to develop a program that would identify patients while they were in the hospital, then refer them to a telehealth program where we would monitor those patients' blood pressure, their pulse, their weight, and their oxygen saturation on a daily basis. One of the things that we incorporated, which I think has been tremendously important and valued, is we have implemented a patient activation measurement tool, which was developed out of the University of Washington, Dr. Judith Hibbard. And it's a 13-question tool that the nurses in the hospital ask the patient the questions or give the tool to the patient. And once the patient has answered their perception of their level of engagement, it gives a score between 0 and 100 and places the patient in a level of activation from 1 to 4. Level 1 and 2 patients are those patients who are distrustful of health care, they fear health care, they've had negative experiences, they believe it's the doctors and the nurses' responsibility for their health, health versus owning their own responsibility. The majority of these patients are non-compliant. In the last presentation, you saw the slide for patients who are unengaged, that their 30-day hospitalizations, et cetera, are much higher. So we decided to implement the patient activation measurement tool. We actually have it in our electronic health record, and we only focus on patients that are a activation level 1 or 2. So we're focusing on the most unengaged group of patients. We started our program February the 1st. I just got an update from my team. We have now enrolled 496 patients into the program. We started, as I said, February 1st with 200 sets of monitoring equipment, and we started at 4 of our hospitals, 3 rural hospitals, and then the Vidant Medical Center in Greenville, North Carolina. We also partnered with ECU, their geriatric division, and are monitoring patients that are homebound with chronic disease. So our focus is strictly on chronic disease, patients who are frequent readmission patients, and patients who have low activation levels. Between February 1st and the end of March, we enrolled 200 patients into the program, and then we obtained 180 additional sets of equipment and are now rolling those out to other hospitals. By the end of September of this year, we will have 500 sets of equipment rolled out to all 10 hospitals, as well as the Vidant Medical Group, which is primary care providers. With that approach, we're really looking at how can we proactively identify patients to monitor before they get into the hospital. I want to talk about lessons learned, because there's a lot of people that are doing home telehealth or remote monitoring in the patient's home, and I was very disappointed yesterday when hearing from CMS that they don't see the value yet in this. So one of the big things on lessons learned is develop your program based on the new payment structure. What we did is we looked at who our core measures, what we're going to be publicly reporting, looked at where we are on the linear graph of value-based purchasing to make our determination of the focus of patients. We have to shift from hospital care to care at the home. Patient is always going to be the center. In our program, everything we do, everything we say, how we act is through the patient's eyes. If it's not, that behavior is called very, very quickly, because this is all about the patient. There's a lot of research out there on care coordination and transitions in care. Those are great programs. However, the models for those programs, the ratio of nurse to patient is between 1 to 18 and 1 to 30. When you have ratios at that level, it's very hard to scale a program. It's not affordable. Our ratio of RN, registered nurse, to monitoring patients is one nurse to between 85 and 100 patients. So this is a program that you can scale. It also requires that you change the way hospital case management is run. Most of hospital case management programs were started, the last model was in the late 90s, and we have to move forward. And then, of course, patient-centered medical home. We have 4 of our Vidant medical groups that are going for certification as patient-centered medical homes, and they have incorporated telehealth into their programs as well. You need to focus on the top 5% of your users, high-risk patients that age, but you'll see in a minute when you see our data, it's very sad that a large majority of our patients are between the ages of 18 and 60. Assess their engagement and then teach and coach based on that activation. Don't have much time, but I want to give you an example. One of the very first patients that we installed was talking to the team about goals for the patient. It has to be patient goals, not nursing goals or physician goals. We ride up to the patient's home, 54-year-old patient with heart failure and COPD. She's standing on the porch smoking. Well, that's bad enough. So I said to the team, okay, number 1 goal is what? We talked about that. We get up to the home, and there's big signs on the door, no smoking, oxygen use. She opens the door with the lit cigarette and walks in. So I look at the team, and I said, now what is goal number 1? Then we go in our home, and there are literally medications everywhere. So I said, what is goal number 2? Get all these meds together. So for the majority of these patients, it's tiny, tiny, tiny little steps that you're having to take with these patients to get them engaged. I believe in inclusive patient selection criteria versus exclusive. Our only exclusion criteria is that the patient does not have electricity. And of the 496 patients, we've had 10 patients thus far that did not have electricity. You need to have standardization as far as patient identification, screening, and referral and enrollment. You need to have a provider plan of care. We have that in the ambulatory electronic health record. We have a physician referral in our inpatient electronic health record. We utilize LPNs to do our equipment installation and the training of the equipment and competency validation, and they also do med reconciliations at discharge and the day after discharge when they install the equipment. Time's running out, so I'm going to move forward. It has to be data-driven, as we've heard over and over and over again. These are some of the data points that we are collecting. Financial data is absolutely important. When we first started this program, my walk-in orders were you were only to monitor these patients for 30 days to prevent the 30-day readmissions, because that's where we're financially hurting. I met with our Vice President of Finance last Wednesday, and I was very concerned because the 3 rural hospitals that we implemented this program, the last 4 months, they've had 0 hospital readmissions for heart failure. And so I was very concerned that we had accomplished, but when I met with him, he said, move forward, move on, because every Medicare patient and self-pay patient, we lose money. And so we have given the responsibility for the financial analysis to the Vice President of Finance for Vidant Health, because there's no way that I could provide them what they want to hear. EHR integration is critical. We are going to be going live with our phase 2 integration between our telehealth vendor and Epic on September the 4th of this year. Before we could get the entire integration, it was a painful process. The telehealth vendors are willing, ready, and able to do this integration. It's the electronic health record vendors that we really need to be pushing, that they have to do this. They're being paid for meaningful use. They have to come to the plate. They started initially, it was going to charge us $20,000 for this integration. That's ridiculous. We got them down to $5,000. We have built-in flags, standing orders, etc. Roadblocks, capital is most of the roadblocks for a program like this. Lack of reimbursement, but really that's not a barrier for us, because we're not looking for reimbursement for the program. We're looking at this as a cost avoidance and cost savings for the organization. 54%, so far we've had, of the 496 patients enrolled, we have had 65 patients who have been monitored. The average length of stay you'll see in a minute is 60 days. I kind of went over that 30 that I was given marching orders to do. They just gave me approval last week to extend that to 90 days of monitoring, because we are focusing on the most unengaged patients. It takes longer. Of those patients, we've had 65 who have completed their monitoring and have been off the program for 3 months. So how we have analyzed our data is we have pulled all of the data from 3 months prior to telehealth, then during telehealth, and then 3 months post. So we have 65 patients that have completed. The majority are female, And if you look at this, yes, the majority of our patients are over the age of 70, but look, 12% of our patients are between 18 and 49 years old. We have a 24-year-old heart failure patient. We have a 19-year-old patient with morbid hypertension. And so this is very unsettling for me, because in my past it's always been focusing on those patients above the age of 70, but with this, our age between 18 and the age of 60 is growing rapidly. The majority of our patients are African American. Average length of stay is 6 months. Primary diagnosis is heart failure and diabetes, and hypertension following behind that. And primary insurance is Medicare. We are not focusing primarily on Medicaid. Every once in a while we'll have a Medicaid patient, but we have a statewide program for taking care of Medicaid patients. Our outcomes for those 65 patients experienced 100 hospitalizations the 3 months prior to telehealth. During telehealth, there were 19 hospitalizations, and the 3 months post-discharge, there have been 8 hospitalizations. And this is the percentage reduction because I only have 10 seconds. Hospital bed days, those 65 patients, the 3 months prior to telehealth and remote monitoring, there was 489 bed days. During telehealth, that decreased to 76 bed days, and for the 3 months following, it's decreased down to 24. Now, is that a good thing or a bad thing? It's a very good thing. Because if you can decrease medical bed utilization, you can backfill those beds with surgical patients and other paying patients. Also, this allows for us to be able to transfer back to the community hospitals and get the patients back in the community where they need to be. And that's it. Thank you.
Hello, I'm Dave Clifford. I'm from Patients Like Me. We're an online platform for social networking for people with chronic illness. I'm going to talk a little bit today about what we've done so far and sort of a little bit about the direction that we're going in. My background is as a technologist. Prior to joining Patients Like Me, I was at an organization called the Defense Advanced Research Projects Agency. I was at DARPA for 7 years. Did a lot of work in telehealth and telemedicine there. One of the main reasons I came to Patients Like Me was because they were uniquely positioned at the time as a generator of data. So there's a lot of times when we talk about remote monitoring technologies, when we talk about what kind of data we can gather from outpatient life in the patient-centered medical home. And this was a sensorless, cheaper way to get at some of those patient outcomes. Unfortunately, this scales are less zeroed than I would like, but we'll talk about that. So, next slide. Patients Like Me was founded because of this guy. This is one of the three Haywood brothers, Stephen Haywood. It was founded by his older brother and his younger brother. And Stephen here is pretty far along during a progression with ALS, Lou Gehrig's disease. And one of the things that they found when the family was going through this, it's a family of engineers, is that the quality of data about people with ALS in the literature is limited to very small cohort trials. And there's not a lot of information in those published manuscripts about what day-to-day life is like. You can pick up Stephen Hawking's book, and sometimes he'll talk about what it's like to have ALS. You can look at the experience of someone like Lou Gehrig and find out a little bit what it's like to have ALS. But as an average person in the late 20th, early 21st century, what is it like to have ALS? There was no place for someone to come and talk about what it was like to have that disease or many other chronic diseases with a data-driven perspective. There are places where you can go and blog about it. There are places where you can go and write about it and have a lot of narrative content. But what they wanted to do was supplement some of that narrative content with data content. I was going to say dating content. Part of this came about because one of the founders was trying to populate a trial for ALS. And he could go on OkCupid and find a woman who was in his age range, had similar interests, pick on hair color, pick on proximity, but he couldn't do that for a clinical trial. So what is it today? Today it's an online network of over 150,000 patients. Those are people who have signed up to use the website, seeking to connect with others like them for personalized learning and support. And what they do is they enter information over time, and it graphs the information. So they have an immediate visual perspective on what their disease course has been like. And they can use that information to dive into the richer community experience, to find out the people that are on the same medications as them, that have had the same disease as them for the same amount of time. Or maybe that just share common symptoms but have a completely different disease. They talk about their primary diseases and their comorbidities. And a lot of this helps activate the patients, as we were talking about earlier, move them from those earlier levels, level 1, level 2, in I feel like I'm in control of my disease, higher up along that patient activation chain. So what does a profile look like? Here's what someone's profile looks like. This person has a public profile, which means that if you Google this, it'll show up on Google. A very small percentage of people have public profiles. Most of them have private profiles, which means that they're able to be accessed by other members of the Patients Like Me community. Most people use pseudonyms. We know their email address for adverse event reporting, but because we have to have a way to contact them, but we don't know their real name. We know their location when they share that with us, and a lot of people don't use a picture of themselves. But people are surprisingly, in this community, people are surprisingly open about a lot of severe pathology. They score quality of life, which is correlated to the SF-36. This is a person with multiple sclerosis. So they've got an MSRS score, which measures their multiple sclerosis progression. This is a questionnaire that's administered to them, and they choose to take the questionnaire as often as they want to. They can set up reports, take it weekly, monthly, etc. You can click on that, and it'll break it down into the different domains that the MSRS measures against. In ALS, we use the ALS-FRS. We use a Parkinson's score in Parkinson's. In many of our communities, we haven't developed scores yet, or we haven't adopted scores from the literature yet. And the majority of patients using our site have severe neurological diseases, ALS, fibromyalgia, Parkinson's, epilepsy, not some of the big drivers of care in the remainder of the population, the things that are COPD, myocardial infarction, etc. They track medication dosage and strength on a Gantt chart. If this person switched medications, dosages, those bars would be bigger over time. So it's visually intuitive. And then they share symptoms on a non-mild, moderate, severe scale. So this is a person with MS, but you can also see that they have OCD symptoms up there as well. So we're looking at their comorbidities, which frequently when you're looking at an EHR from the clinician perspective, if you're in nephrology, you're seeing the nephrology relevant things. You're not seeing necessarily the entire picture of the patient today, although that's, changing. So this looks at a community, what's it like to have epilepsy, and this gives you sort of a sense of, okay, I have epilepsy, and one of the things that I'm concerned about is headaches. How often do people have headaches as frequently as I do? And you can look at this at a glance and get a sense for this. You can look at, what medications are most prevalently used and the evaluations of those medications. What are some of the side effects of them? How severe are those side effects? And then you can go into this discussion on the right-hand side, where people are talking about what it's like to have epilepsy in more of a narrative view. So this is interesting. It's a place where people could come and get together and talk about stuff, but is there a benefit from it? I think in the context of rural health, one of the largest benefits that we can see is that 1/3 of the people in our community had no one in the real world to discuss their epilepsy. And in the cases of stigmatized diseases, in urban populations, you can find a support group. In rural populations, you can't necessarily find a support group. So this provides a 24/7 access to a support group at 2 in.the morning if you're in Beaufort, North Carolina, for example, and have one of these life-impairing conditions. For a majority of the people with epilepsy, the site gave them a better understanding of their seizures because we ask them what sort of seizures they have, and we provide them a description of what some of the different seizures are. So they go from calling things fuzzy wuzzies to tonic-clonic, even though that's sort of now inaccurate or less accurate. For half the patients, help them understand their side effects. This drives them to be more adherent to their medication in many cases. People frequently discontinue medication because they don't know if something is a side effect because it makes them feel weird or feel strange. And epilepsy in particular, and epilepsy adherence is the difference between continuing to have seizures and not having seizures. There's a large percentage of people with uncontrolled epilepsy that is, the epilepsy in those cases is uncontrolled because they don't take their medication. 21% because they're using the site and getting access to better information, they insist on seeing a specialist. So this is positive across the board for many of these people. So what do we do? From a broader view, we're a novel sort of patient registry. We're a complementary source of data to this remote monitoring world and to this care world. And we're more closely integrating with the other data streams as the other data streams are becoming available. We talk about patient centricity and patients being owners of their data. Very few care systems have adopted good places for patients to be meaningful custodians of that data. So, for example, the Kaiser Health System has spent a tremendous amount of effort building a very good patient portal. Their patient portal is frequently used by their patients, but that represents enormous time and enormous resources. On the other hand, there's something like Google Health, which Google went into and said, we're going to create a home for people to upload their medical records independent of their care teams and independent of other health-related environments. And that was a catastrophic failure. That's been discontinued. It doesn't exist anymore. Because when people are trying to manage their health online, they are trying to do it in the context of other information. They're not trying to do it in a sealed vacuum. So if I can put my personal health information somewhere and I can share it with someone, whether that's my clinician or my peer group, that's better than if I can put it somewhere and then bring it to someone else in some other part of the system. Both of them are exceptionally functional and necessary tasks, but it seems as though for the broad majority of people, there's less of an interest in that personal health information management as a good on its own. For providers and for care teams, we provide clinically robust understanding of the patients and real-world outcomes. So we aggregate the data and then supply that data to people who are interested in that patient information. We provide bidirectional lines to patient voice. So one of the things that we found is that multiple sclerosis patients, for example, frequently take their biologic medications at night rather than during the day. And this is not something that clinicians frequently tell them to do, and this is certainly not something that a GP often tells someone to do, but it's something that other patients tell them to do because the side effects are very severe. These medications. You feel like you have the flu when you take these medications. And other patients know that you feel like you have the flu when you take these medications, so you should take them at night. And the drug companies, the drug manufacturers, and the clinicians aren't as aware of that information because, as we were talking about, there's this information explosion. The information is proliferating at a much higher rate than someone can put their hands around it. Additionally, we have this breadth and adaptability of social networking and crowdsourcing. Earlier, we talked about the danger of the pediatrician providing bad information, or the person who is interested in doing a search on pediatrics retrieving bad information or low-quality information. And part of that is because in many of these places, the information doesn't have a double check. It doesn't have another person saying, yes, this is wrong, or no, this is right. If you go to Yahoo Answers, it's awful. Don't go to Yahoo Answers if you want an answer on anything, because there's no validation of information, and the people who populate this site are people who feel like they are experts in something or have a lot of time to waste. On the other hand, people on Patients Like Me are people who are seeking health information and have at least some personal experience to reflect on when they're sharing that information with others. And the presence of data as an underlying pin to these narrative threads allows someone who says, I'm thinking about undergoing liberation therapy, which is a drastic therapy that's not well received in the peer-reviewed literature, I think is the generous way to describe it, but involves essentially catheterizing a vein in your neck to alleviate MS symptoms. Now, there are people on our website who have gone through that and continue tracking their data afterwards. So when someone comes and says, I'm thinking about undergoing this, and the community can say, okay, we would suggest you look at these 30 people's profiles, or these 40 people's profiles that are a set of people who have undergone this therapy, and see what happened to them afterwards. And for the majority of these people, regressed to the mean. It provided them no long-term benefit. So it allows there to be a data-based double check for some of this health information that otherwise just exists in the wild. So this is good. These are good things. The goal, the substantial goal, and I'll finish after this, is building a world where every patient's treatment is shaped by every other patient's experiences. And I think this is, again, a complementary role that patients can bring to telehealth and to telemedicine, especially in the context of things like remote patient monitoring, when we're getting data off of sensors and we're not sure if the data is coming off of the sensor and it's aberrant because there was a medical event or because there was a life event. And in order to zero these sensors that we're putting in the patient-centered medical homes, we need to have some of this complementary data about what was going on in the patient's life that day in order to make these sensors more robust and useful. So there's the telehealth and telemedicine charge of this, there's the patient beneficiary charge of this, but overall, we're just trying to integrate with as many data streams as possible to make the system go. So thank you.
Morning, everyone. So my name is Mo Kaushal at the West Wireless Health Institute. So thank you for having me. So I'm going to spend the next 10-15 minutes talking a little bit more about some of the future technologies we're seeing within the wireless health space, but more importantly, the other things that have to come together, which I think have been touched upon today, including policy, clinical processes, etc. I think the key takeaway is the technology has to be bundled in with other pieces of the story to really perpetuate this whole space. So briefly around the West Wireless Health Institute, we have one core mission, reducing the cost of healthcare. We do that via internal innovation, external investment, and now also a policy institute here in DC. So a couple of the main topics that I hope to cover. A brief overview again around the transition in healthcare right now. Again, I think the world post-reform is going to be very different to the world pre-reform, which creates a huge amount of opportunity for these real disparate technologies and bringing them together. Secondly, a little bit about the overview of wireless health, and then finally just the state of the industry today. So at a macro level, the forces around macroeconomics are not very positive, but create a real opportunity. And I know I'm preaching to the converted here, but three main drivers that we see: rising costs, the epidemiological transition, and a real shortage of not only doctors, but also nurses, nurse practitioners, etc. So we're spending now around 18% of GDP on healthcare. This is growing, estimated to be around 20% of GDP on healthcare. And this doesn't get us the real value that other countries have. Secondly, and I'm just going to summarize this slide, we have more elderly people coming into the population. And as we know, elderly people have more chronic disease, and unfortunately chronic disease drives even more costs. So this is going to get worse. And then to compound all of this, there's just not going to be enough professionals to look after all these people. So therein lies the opportunity. And I believe technology, especially mobility, can solve some of these issues. So in the backdrop, and I know, again, many of the audience know what's going on, we're having a real shift away from paying for transactions and volume of care to outcomes. So I'm not going to debate whether an ACO is going to work or not. For me, whether it's an ACO, bundle, 30-day, or whatever new flavor comes around, some will work, some won't, but they're all trying to do essentially the same thing. As a ratio, a hospital will get paid more for what goes on outside its four walls more than what goes inside. So from a clinical perspective, if we can prevent costly readmissions, prevent exacerbations, one would like to think that these will be rewarded whatever payment model ensues, and I'm a firm believer of that. So the West Wireless Health Institute, and one of my colleagues, Joe Smith, the CMO, coined a word, infrastructure independence, which I'll go deeper into. But essentially, what do we need to do? We need to shift the site of care from expensive, centralized bricks-and-mortar hospitals managed by expensive physicians and nurses to outside the hospital. And we really need to de-skill healthcare. If you look at labor productivity in many other industries, it's improved over the last decade. Unfortunately, in healthcare, it lags behind, like many other things. So infrastructure independence, essentially, let's compare and contrast. The current model I describe is very reactive. Low-frequency visits driven by an appointment when a physician can see you, the patient, not when you need to see a physician. Very location-centric and very high cost. Again, I see mobility and wireless health to really disintermediate this current process of care. What we really need to do, and it's already happening, we need to move to a very proactive system, very high touch, providing the right treatment at the right time, wherever the patient is. And again, I think we all firmly believe if you can prevent exacerbation of COPD, pneumonia, MI, CHF, all the very large spend conditions, we can really lower the cost at a macro level for these patients. And then home-based care is cost-effective, and there's a lot of data out there. The post-acute space is sort of increasing in cost. But again, if we can pick up these patients earlier and manage them in cheaper places rather than that centralized hospital, we're talking from a nursing home of $80,000 moving down to independent living of $1,600. So even if we shift a small proportion of the elderly population into independent living, the cost savings are huge. So post-reform, here are some of the interesting inflection points that we're seeing. Again, I've touched upon payment reform. Again, I would advise no one to get deep into the debate of which one's going to work or not. I think if we do the right thing clinically, the bet is that it will be rewarded in the new world, and I'm a firm believer of that. The other piece, which I'm going to go deeper into, mobility is one piece of technology and it's not an end-to-end solution. So there's other things going on. We're sort of undertaking this digitization of healthcare. If we look at other industries, data in a digital form and analytics have transformed productivity and outcomes. That's what we need to do in healthcare. So the background of meaningful use is essentially bringing more data into the healthcare system. And mobility, and I'll go deeper into this, is just a piece of that. And the third, again, practical effect of reform, we're just seeing a lot of physicians becoming salaried employees. So hospital systems are purchasing physician offices. Physicians are preferring to be salaried. So again, getting away from that transaction system is where we're going. So let me go now deeper into wireless health. And the taxonomy is pretty extensive. You get mHealth, wireless health, telehealth. It's hard to navigate through that. Here's something that I and we use. Going back to data, let's just go through the different components of that. So there's the data input side, and sensors are a mechanism to capture these physiological parameters. Then think about how do we move around this data via wired and wireless networks. The third piece is how is this data going to be stored, and more importantly, what are the analytics that we're going to push onto raw data to turn it into meaningful information? Again, physicians, nurses, etc. don't want to see raw data. They want to know what to do. And then finally, when we get all this information, how do we push it in the right user interface to the final user? So mobility empowers both extremes of that. It allows the capture of data anytime, anywhere, any place, and the pushing out of information anytime, anywhere, any place. But my hypothesis is that's not enough. The wireless health industry has moved away from just mobility. Analytics, healthcare IT is becoming implemented into telecoms and medical devices. And then I think the final point that, again, is touched upon today, all of this has to be implemented within the right clinical process. So either the existing clinical processes to make them better, but the more exciting piece is how do we create whole new clinical processes empowered by these technologies to look after patients for a fraction of the cost with better outcomes. So now going into some of the technologies that we're seeing. Around the data input side, sensors are becoming cheaper and more ubiquitous. And for me, there's a hierarchy of data. So it's pretty much a commodity to be able to capture blood pressure, pulse, weight. The more exciting things going on, in my opinion, are the higher levels of the data hierarchy. How can sensors be used to capture non-invasively really hard parameters? So think about CHF. If there's a device one could put at the end of a patient's bed which can pick up decompensation 2 weeks before that patient becomes symptomatic, that's a true game changer, and that's what we're going to be seeing as sensor technology becomes a little bit more advanced. And then, again, this whole space has been getting a lot of press for the last couple of years, whether it's The Economist or Science. We've seen now a lot of movement from, I'd say 4 years ago, which is when I started my foray into this whole space. We've seen a movement away from just the convergence of devices and telecoms to now the convergence, as I said, of healthcare IT, service delivery, and user interface and design. And again, I think it's going to be an amalgamation of all these very different disciplines that create the positive final outcome. Again, it's not about just making a device wirelessly enabled. It's around how does this better manage patients for a fraction of the cost. And to do that, it's going to be a multiple of technologies and different disciplines to get us there. And there are reasons for optimism. From a technology perspective and then from the data that's coming out. So some of the inflection points around technology, ubiquitous networks, whether they're wired or wireless, which can transmit more and more information. And I'll touch upon in the end from the work that we did in the FCC. Unfortunately, there's still huge parts of the country which are lagging behind in the connectivity piece, and that needs to be solved. Consumer scale production of smartphones and ubiquitous devices. Again, the amount of apps proliferating on the smartphone, both for consumers, providers, and other caregivers, will only grow. And slowly now we're seeing the ones that are creating a lot of value. Again, the decision support for me is the most important piece. There's a real generation gap now in analytics, in healthcare versus other industries, and we're catching up. So how do we just turn this multi-source raw data from multiple sensors, medication compliance, the EMR, social factors, how do we capture all of that and turn that into something meaningful to figure out levers that we never knew before? And I always put the cost pressure sign up there because, again, 18% of GDP on healthcare growing to 25%, it can't continue. The country will be bankrupt. So the impossible cannot occur. So either drastic changes will occur, which I hope not, or we actually redesign the healthcare system. And then reasons for optimism. I know our colleagues from the VA and the Indian Health Service will be presenting this afternoon, but Adam Dawkins was one of the architects of the VA home telehealth study, and they've got some pretty compelling figures. They've got a 19% reduction in hospital readmissions for people within that program, and for the patients who are admitted, a 25% reduction in bed days. And again, I'm sure they're going to cover this in more depth, but it's not just about the technology, it's the right payment model, it's the right culture, it's the right standardization of processes, it's using care coordinators, and then the right technology to help augment and accelerate that. unfortunately, there are still significant barriers, and this is something that we outlined at the FCC National Broadband Plan a couple of years ago. So let me just go into the taxonomy we use and then go into some of the specifics. We sort of think about a pyramid. The base layer is connectivity. We need the prerequisite connectivity to empower everything. The next level up is just the interoperability and liquidity of data. Right now, data is siloed in non-interoperable systems. EMRs don't generally talk to EMRs. Within the wireless health space, again, the concern is if these front-end devices cannot talk to the back-end data warehouses or the EMRs, we need to solve that. We have to prevent that same problem occurring with the device aspect. And then the next level was integration. How do these different technologies actually integrate together? So in an ideal world, think about the internet. You have basic data liquidity and then apps or programs developed by the best entrepreneurs plugging on top of that. That's what we need to do here as well. The best devices need to be intermingled with the best pieces of analytics, and there's going to be innovation all the time. So how do we get to a plug-and-play technology landscape? And then finally, just the clinical evidence needs to be perpetuated around the final value proposition of all of this. And again, the key point is the technology by itself has to be implemented in the right care processes to get that outcome. There's many cases where very cool technology with a great value proposition just hasn't got there. So again, back to this point, the industry has moved away from, and again, 4 years ago, and back then it was just pushing a lot of technology for technology's sake. I'm seeing a lot more solutions out there now. I'm seeing management teams comprising of the classic technologists, but also people who understand healthcare policy very well, people with clinical expertise to understand the care processes, and then people from the payer and provider world coming in. So is this combination of team that we're now seeing in raw startups that I think will disrupt the landscape versus just the technology piece or just the policy piece. So in summary, again, it's multitude of technologies that need to work together, and it needs to be implemented in the right care process, which again I've said about 5 different times, but I truly believe in that has to be the right way. Thank you very much.
Thank you. That was excellent. I want to sort of summarize what we just heard, and I think all of these 4 presentations came together really well. I loved David's point about it's not about the technology, it's about the people and the processes, and then every other speaker repeated that. So that that really resonates, I think, with me and with everyone here, that it is not, I mean, technology is a tool, it's an enabler, but we really need to get everything else to center around there and come together. I think we heard a lot about who should be the custodian of the data. I think, Dave again made a good point about the patient being the custodian. We then heard about patients generating their own data. Now they're not only should they own the data that we generate for them, but they're generating their own data, they're validating their own data, and they're finding this data useful. They're sharing data amongst themselves, and they're finding support in there, and they're looking at trends, and they're doing things that we used to do in the past era. And then, there are issues that we need to work on, like privacy, security. But the other thing, a message for the industry, I think, is about reliability, that we sort of need to start thinking about how to make this data reliable and how to make these sensors work perfectly and how to get there. And then intuitive data collection. And I think a couple of speakers spoke about that. We need to integrate the data collection into the life flow. And maybe wireless and mobile is the perfect answer, because smartphones are with you all the time, and they're part of your daily routine, they're part of your daily workflow and life flow. So it feels like all of these things sort of give us the same message. And I think we're open to taking questions. But I can start off with a few questions. We have about 20 minutes. Okay, there are already questions. So I'll stop talking and I'll turn it over to the audience.
Sorry, I was just wondering if I could make a quick comment about wireless health and mHealth in general. Do you mind if I just supplement what you were saying about mobile with just some... So I go to a lot of these meetings, as many of us do, and frequently people talk about mobile technology being the technology of the future here, and mHealth being a big disruptor and a huge game changer. And year over year, the number of apps that you can download for health has gone up dramatically on the App Store. And when people are surveyed about usage of these apps, most people open these apps after they download them. About 20% of them open them once. And of that, after 30 days, about 4% of them are continuing to use a current app for health. Now, this could be for a lot of reasons. One, the apps don't exist, don't integrate in any kind of life flow currently. And don't forget that Apps for Health includes things like Runkeeper, includes fitness apps in that overall Apps for Health. It's not, am I managing my COPD, am I managing my diabetes well? So people are frequently very, very big cheerleaders of mHealth and mHealth adoption. But the mobile app development community isn't going to invent the solution without the other players at the table. They're not going to do it on their own. So this earlier, David Munn said, if you build it, they will come. 6 years into the enterprise at Patients Like Me, that is absolutely 100% not the case. If you build it, and they look for it, and they know where to look, and their clinicians are guiding them there, and they're finding some utility out of it, some of them will come. So people talk about technology solving the problem of healthcare, and I think that what this panel pointed out was that technology can only solve the problems of healthcare insofar as it's integrated intelligently into workflows and like flows and clinical flows. And I would say that the problem is not the intelligent technologists inventing interesting technological solutions. I would say that the problem is the clinical workflows that are not paid to adopt any of those solutions. That's my 2 cents on this issue.
Absolutely. I think that ties into my point of an mHealth developer being part of the care plan so that he actually facilitates what we want to do with care and not build something that no one's going to use. But anyway, thank you for that comment. Sure, Nina.
I'm Nina Antonetti from Marshfield Clinic, and I just want to echo your comments on mHealth. I do a little bit of speaking on that, and one of the examples I use is smoking cessation. There's a smoking cessation app that's one of the most widely downloaded apps, and it's used for 2 weeks by most people, and they never use it again. But one of the things that's consistently used is the cigarette calculator, which you can put in how many times you smoke a cigarette, and then you can work on decreasing the number of cigarettes you smoke. It also calculates how much that's costing you, and most people, 95% of people use that to figure out how much to budget for cigarettes. So it doesn't really help them to decrease. I think health apps need to be written by clinicians. That's the only way we're going to reduce the statistics on the errors in mobile applications. And I think it's interesting. There's an app, a travel app, for you can just put in there, I need a taxi, and it GPS locates where you are and calls a taxi to you. I stood at the corner yesterday for 20 minutes waiting for a taxi, and then I think I saw Bonnie and Karen waiting on another corner for a taxi. Why aren't we using call us a taxi apps? But my main point I wanted to ask is part of this workshop as one of the planning committee members is to really to engage people and to do something after this. I'm kind of an action science kind of person. I like to make sure something happens after we get all the data together. And as the chair of a national work group supported by the American Telemedicine Association on remote data management, I'd like to invite, and Bonnie's already a member of this group, David and Mohit to join. To be either some of the authors of the National Standards for Remote Data Management, which is, again, everything we've talked about in your session today, or at least help us be a reviewer for that. So I'm going to come and find each one of you after your session is over. Thank you.
Go ahead.
Dr. Schwam from Boston. I wanted to ask David, but some of the other panelists as well. One of the very interesting things that I've been noticing is patients starting to aggregate themselves and identify researchers who are interested in studying their conditions, which is a very interesting turn from what we think about as traditional clinical research. And there was actually a recent negative trial published that was aggregated through patients studying the effects of lithium on ALS, which I'm sure you're aware of. So what I wanted to ask you is 2 things. Number one, what do your members, if you have any way of asking them, what do they talk about in terms of how they would like to connect with providers using technology? Are they looking for face-to-face interactions that are geographically and physically easier for them to accomplish because of their debilitating conditions? Or are they looking to supplement their traditional interactions with easier access to answer a question for me quickly, or I want to be able to ask you questions in a way that's easy for me? So maybe you could sort of, number one, just tell us a little bit about what are they actually looking for, and number two, do you think that there's a role or that there will be an evolution toward patients really essentially taking over a portion of this space and being the ones who decide, for example, we want this question answered, issuing the RFP for the research question rather than the other way around?
So I'll answer the second question first. There's a guy named Stephen Friend who runs an organization called Sage Bionetworks, and they're a multi-million-dollar research nonprofit located in Seattle, Washington. And one of the things that he's trying to do is build a new health commons. And part of that includes this thing called portable legal consent, which is the ability for any person to consent to a global IRB and allow the data that they can assemble about themselves from the electronic health record and other data sources to get aggregated into an open database that is then used by researchers around the globe, really, for the purposes of research. Now, you can consent to this now. You can sign up for portable legal consent now and start to enter in some of that information in the database. But another part of this is a project called Bridge that he's outlined. And what Bridge is seeking to do is to be this sort of, I would say it's a Kickstarter for medical research. So a bunch of people can get together and say, hey, here's the research question we're interested in answering. This is the data that we have available. This data is available on this website, and we'll give a $10,000 prize to whichever researcher can come up with a more apt model for it than the one that we have today. That's happening. I don't know what the timeline for that's going to be like because it is very much counter to traditional research. I don't think anything that was started that way would get through peer review, and I don't think that anything that was started that way would probably end up with a small molecule through a phase 1 clinical trial, because I don't think that there's a good way to aggregate enough dollars, but maybe it could be used for the preliminary results in an SBIR. The secondary question you asked me was, I'm sorry, just remember, regarding what motivates our patients. Our patients are not normal patients. 99% of the patients on our site don't get any questions wrong when you ask them health literacy questions. They score perfect on that test, and the ones that get questions wrong get one question wrong. These are people who are very engaged in their health and very engaged in health data, so I wouldn't look to them as being a source for what patients want. These are people who use the internet as part of a normal routine to seek care and to seek health information. That being said, 20% of people with epilepsy that we surveyed fired their doctor. This is not uncommon. It's a narrative thread that's throughout our different patient communities. Patients want doctors that talk to them as though they are intelligent human beings. That's the biggest thing. Patients want doctors who allow the patient to be a participant in their care. And for the most part, I don't think these people care if that's over the phone or over the internet or over Skype or face-to-face in this population. What this population wants, and again, these are people with severe neurological impairments, so these are a separate set of people than the people with COPD, than the people with type 2 diabetes. It's just a different sort of chronic impairment. What these people want is to not be treated as though they are disinvolved or disintermediated from their care processes. And they want the best quality information they can get, and they want to have a dialogue with their providers. And I don't think they care about the technological implementation.
Can I make just one comment about clinical trials? And it ought to be particularly interesting in this building to talk about it, and that is that health information exchange needs to take into account the fact that somebody is enrolled in a clinical trial, and the fact that somebody is admitted to a particular venue for some kind of treatment can significantly impact the course of that clinical trial and can either advance or retard clinical research if it's not handled properly. And so one of the things that we need to be very aware of is the clinical connectivity, and in that continuum, we certainly should be talking about clinical trials. The place I came from, we had 900 clinical trials going on. Very few of the physicians inside the organization were actually aware of all of them, so there's an awareness issue. But we did have to write parochial interfaces, if you will, so that every time a patient came in, it queried the database of all the people enrolled in a clinical trial and would send an alert to the clinicians, and it had an incredible impact But to do that across boundaries is where we need to go. So I'm happy that we're talking about incremental success, but we also need to be planning for some of the more the loftier goals that we should have as well, which is to promote clinical research. I had to say that in this building.
My name is Chuck Dorn from NASA headquarters and also from the Telemedicine Health Journal. This morning we heard about evidence and we just now heard about technology, and obviously there's a lot of data out there, a lot of publications in a variety of different journals about the good and the bad about technology. But my question really is regarding the adoption of technology. If I look at Laennec and his stethoscope in 1815, and I look at Röntgen's X-ray at the turn of the 20th century, not a lot of peer-reviewed science proved or disproved the use of those two tools. Yet telemedicine seems to go through this, constant, well, we need the data, show us the data. But how does this all then relate from a technological perspective to the development of federal policy? If I'm now being able to buy a smartphone that can do all these different apps, whether they're acceptable and whether people use them or not, and they change every 6 months or so, how does federal policy change, and what are some of the challenges that you see from a technological perspective in the adaptation of that or adoption of this in healthcare?
Pointing to me, so I think technology innovation is always going to outpace, or in most cases outpace, regulatory or policy innovation. And there's a time gap. And to your point, many of the technologies within telehealth have less of a value proposition in a fee-for-service world. So for me, working tops down, I think we really need to nail the payment models, because it's funny how basic economics will cause adoption. So I think that's the most important thing to grapple. I'm less worried about clinical process innovation, culture change. I think once the right incentives are set there, decentralization and empowerment within different provider systems will figure that out, but they have to get paid for it. So I think from a policy perspective, that's the most important thing to figure out. If that's done, and then also some regulatory clarity around how innovators can get some of these solutions through the FDA regulatory process, those are, I think, the key levers. The rest of the stuff, I think, has to be figured out by innovative people in the ground.
Well, I think, if you go, just to interject a comment, in 1933 there was a Telecommunication Act, which didn't change until 1997. And from 1997 until 2012, you know what kind of technology we've had, gone from beepers to smartphones to wireless telecommunications. And so today things change so rapidly, I'm concerned that the government can't, is either unwilling or the process is, we haven't thought outside the box, and we have to start thinking about how we can make those changes more rapidly because this technology is changing.
Yeah, I'm just coming from ONC. I need to say that I've seen the impact. I was on the other side of the table as a CIO when the changes came in, and I can tell you, I started work in a hospital that was built in 1969 without a medical records department because the founder was told that he could put a computer in the data center and actually have an electronic health record. So the notion has been around for 50 years. I mean, this is an easy thing to see. The question is, what did it take to get us to the point where we're going to do something? And the truth is that the markets weren't efficient. And a lot of people were developing software that wouldn't talk to other software. And so the government really is, if you will, the last resort when a market doesn't do things as efficiently as it could. And so I think putting stimulus money out did exactly what both of our prior presidents wanted to do, which is to computerize the records for all the Americans in a way that it couldn't have done without government intervention. And so it's not that we want that to happen first, it's we want it to happen when other forces won't let it happen. Well, what I think you will see is that we will get to a critical mass more quickly, and we're seeing that already. And I think the other thing that needs to happen, and this is not where the government should play a role, it's where private industry should play a role, and universities as well, and that is publishing the value propositions that are associated with all these technologies. But what is going to be the forcing factor that causes people to finally start to connect and collaborate? And I think that's where government did have a significant impact. So part of the reason I was drawn to the Office of National Coordinator is because of the work that had been done that I started it 40 years ago when we started writing for electronic health record. So I think the regulations that are available now are forcing interactions in a way that creates more of a commodity-like use of the data. And the data is the powerful driver here. And critical mass is not such a large number. It's usually defined as the square root of n. So the question is, when will we have enough critical mass to move forward? And when when we start exchanging data freely and we truly get liquid information, I think you will see the changes occur.
My one concern from a regulatory standpoint is complementary or orthogonal to this, and that's when I pull out my Android and I pull up an app and I'm using the data from the ecosystem to make a clinical decision. The FDA has indicated that that's something that they want to regulate, and the standards for them regulating that sort of algorithm or that sort of application, to me, as someone who cares about mathematics, statistics, and risk, don't make much sense.
Paula Shireman, UT Medicine, San Antonio. I've really enjoyed all the presentations this morning, and Bonnie, I was especially delighted to hear what you were talking about. As a vascular surgeon, I have the whole gamut of patients that bring to me things from the internet and say, why can't I have my endovascular stent graft, or should I have that, versus ones that just want to be told what to do. I mean, physician as advisor versus physician as parent, essentially, that goes through the whole. How do we come up with the payment systems to enable us to do exactly what you've done? Go into the patient's home, get their medications set, go to get them to their appointments. I mean, I have a high no-show rate because they can't even get to the appointment. So how do we, and that of course will increase costs. In the long run, it'll decrease costs, but it will, and the patients that you're talking about that don't take responsibility for their own health are just more expensive to take care of usually than the ones that are on the websites.
My comment to that is, from a policy perspective, you have to act local. You know, so for us, our number one objective is to convince Medicaid of North Carolina that a program like this would be beneficial, and worth the value of reimbursing. And we're pretty close to doing that. I think from a policy perspective from the federal government, our biggest, I think one of the biggest issues is we have not done the randomized controlled trials. And the primary reason we have not done that and aren't doing that now is because the need is so urgent. And from the hospital's perspective, as well as from the patient's perspective. And so, you know, I've always believed in randomized controlled trials. However, in this case, the hospital doesn't care about a randomized controlled trial. They are concerned about how to change the way they deliver care so that they can exist. And I think that that's the biggest thing, and it's going to be, it's a great thing so that we can get the hospitals to move into ACT to take care of these patients and wrap services around patients that are the most vulnerable. However, from a policy perspective, it's going to be very difficult to have policy change because we don't have those trials.
And that actually leads into my second question about research, which is also very near and dear to my heart. Programs like yours could be the pilot data and preliminary data in the grant world to then lead to exactly what you're talking about. And can we somehow link up with National Institutes of Health, with the clinical translational science programs, the CTSAs that are across the country, in linking some of this research exactly to that? I love the idea of a national research database. The CTSAs have been taxed with the idea of, can you, even across institutions in your own CTSA, come up with combined IRBs so that you don't have to spend all your time processing consent issues rather than actually doing the work. And then there is, of course, a push with the CTSAs to make it a nationwide network that hits a lot of research universities. So can we somehow partner with that? And once again, another government agency getting another government agency to talk to each other to actually forward our agenda.
I think that's a great idea. and something that I was not aware of. One of the things that we're having discussions in the state of North Carolina, actually, we're having a telehealth summit September the 12th, and my thought is that why can't we as a state or a region of the country start a chronic disease consortium where you can have centralized remote monitoring to keep costs down, to keep standardization in place, and then have a repository of data within that state or within that region so that we would have the ability to do 1 IRB, we would have the ability to bring all of that data together to have greater numbers to be able to take to Medicare and the federal government. That's a great idea. Do you want to comment?
I was just going to spout heresy for a few minutes, if that's all right. So, the randomized controlled trial in medicine is outlined pretty well in a document written by a guy named Ibn Sina. And Ibn Sina wrote the Annals of Medicine in the 11th century. This is pre-calculus. We need to tell what an effect a drug might have in a population because we don't know anything about biology. We know that sometimes we give people herbs and plants, and sometimes they get better, and sometimes they don't. This is experimental, fundamental things. This is not, I can put a pulse oximeter on a guy, I can put an EKG on a guy, I can put an ECG on a guy. I can get ground truth, sensor data, what's actually going on in this person's physiology from the second I start an intervention till the observational period is concluded. The data that I'm sure Bonnie's collecting on the hundreds of people that she's putting numerous sensors on outstrips most of the data, outstrips the density of data collected in the Framingham Heart Study over a 5-year period. I would guarantee you that. And yet, we look at these large cohort studies of interview-based data, of clinical follow-up-based data, when we have actual data from physical sensors that tell us something about the real world, and we say that the actual data from the physical sensor that we have that tells us something about the real world is less valuable than about a group of people who are carefully collected from inclusion and exclusion criteria and most likely engaged in the clinical trial because they were located in a proximal geographic area to the site where the clinical trial was located. So they were located near a hospital that was getting a lot of money to do a clinical trial. This, as someone who is not a clinician, as someone who is not a medical person, as someone whose background is in social sciences and physics primarily, this disgusts me. That we still hold the RCT on this pedestal when we have good, rich sensor data that we can do real math on. We don't have algebra anymore. We have calculus. We need to live in a world where calculus exists and where supercomputing exists and stop holding the RCT to this gold standard. It's a 1,000-year-old standard.
I love heresy. The randomized control trial has a place in the research armamentarium, and CTSAs go all the way from T1 to T4 research, which essentially goes all the way from a molecule in a test tube or taking a plant and finding some wonderful new compound that saves the world or doesn't, all the way to dissemination science and how do you get physicians to do evidence-based medicine, why are they resistant, why are their patients resistant to it. So the randomized controlled trial is here, it's here to stay, but it's only one part of our armamentarium of research. And as technology grows, as we become a smaller and smaller world, that's exactly what we need to do, is new research techniques that forward what we need to do.
Okay. We have time for one more question. So,
thanks. Hopefully this will be a short one and a quick answer. And I'm going to direct it right to Mo because you and I have interacted before, and I don't know if people know you're one of the major architects in the National Broadband Plan, particularly Chapter 10 on healthcare. So we had a discussion yesterday about broadband and the FCC. What do you think we need to do to make what you just said, make ubiquitous wireless, ubiquitous, affordable broadband connectivity available to every American in their home, at every facility?
Yeah, great question. So I think we have to divide, and per Dave's point, there are areas of market failure, which I think is where the FCC and government has a role of intervention, and there's other areas where there is no market failure. As the cost of implementation and of implementing technology and the cost of building networks and the cost of managing them decreases, more and more parts of the country will get there. But I know what you're asking specifically around the rural healthcare program and specifics of where the FCC has a role. And so I've been out for a bit. I couldn't really update you on what they're thinking through, but we can have a chat later maybe.
All right, that just on time. Perfect. So I want to thank our panel. This is a very interesting discussion, and thank you all for your lively conversation and being part of this.
Remember how to use one of these still.
And thank you to our audiences on the webcast.
Thank you. By the way,
so for more of the housekeeping, I just wanted to mention before we lose people online and here, people have been asking, this entire webcast will be archived on the project website forever, so people will be able to access it when they want, as well as the individual presentations, so you'll be able to look back on a lot of the rich data that's there. We're going to start sharply at 12:15. Our afternoon is actually extremely packed, so we're going to do our best to stay close to on time. For those in person who were here yesterday, if you remember, if you're a speaker or part of our committee, we have lunch for you toward the left, and everyone else toward the right to our cafeteria. The cafeteria does close at 1:45 today, so if you want to get something to snack on, although again you can't eat it in here, but you can be out in our atrium to enjoy that. So thank you.
thank you very much.
Sure.
They're always like, we want to talk to people who have lots of data. To get past